Is that right? Vicki, you want to call roll?
Okay, Phyllis Bartlett. Here. Kevin.
Here.
Miss Carol.
She's coming, says she's coming.
Okay, Tanya Christopherson.
Here.
Dr. John.
Here.
Matt Duga.
Here.
Katie Landry. She's on her way. Neil Lemaire.
I did not hear from you.
Mr. Brunel.
Here.
Mary Jane. Here. Miss Nancy.
Here.
Mr. Butch.
Here.
Me. And Laura Smith.
She's supposed to be coming too, but
So that makes 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
so we have a
We
quorum.
have a quorum.
Next item on the agenda is approval of the agenda. Can I have a motion to approve the agenda?
Let's open.
Brunel,
And I'll second.
could I also have an amendment to the agenda? It will
Yeah.
take a unanimous vote.
And I'd like to make that amendment if we can.
Okay,
Okay, basically the amendment would be for a discussion or an action related to the October meeting.
yes, I've had a request to see if we can change the date. So if no one objects, can we add that to the agenda? Is there a second to Butch's amendment?
Second.
John Downs, seconds. All those in favor of the amendment?
Aye.
Anyone opposed? So we'll add to the agenda a discussion, and I'll put it towards the bottom after Lynn's report. We need a motion to approve the agenda as amended.
So moved. Second.
Brunel makes a motion, Butch seconds. Next item is approval of the minutes. Is there a motion to approve the minutes?
Vote on the motion.
Oh, I'm sorry, I thought we did. All those in favor?
Aye.
The agenda is amended. Anyone opposed? Next item, approval of the minutes. That Vicki did such a great job for. Let's approve the ones from May 31st first. If I can have a motion to approve those.
So moved.
Phyllis?
Second.
Butch seconds. All those in favor?
Aye.
Anyone opposed? Next minutes are from April the 25th. Do I have a motion to approve those minutes?
So moved.
Butch?
Second.
Brunel seconds. All those in favor?
Aye.
Opposed? Minutes for both meetings are approved. Before we do go to 2.3, let's, Lynn, can you look at your calendar, and Trish? I was asked if we could move the October 24th meeting to either the 17th of October or the first week in November. Is that a possibility?
17th is fall break.
Of October, yeah, that would be fall break, so that would be difficult because teachers aren't, our staff is not available at that time.
Okay, what about the 25th of October? That's a Wednesday. It would be the day after the 24th. Does anybody have a problem with October 25th, a Wednesday? Okay, can I have a motion that we move our October 24th meeting to October 25th, a Wednesday?
So moved.
Which moves, is there a second? And I'll send out an email to everyone since we have so many absent. All those in favor of October 25th?
Aye.
Aye.
Anyone opposed? Is that good for you, Lynn, I hope?
We're fine.
Great,
Okay.
thank you. Okay, next item on the agenda, which is 2.3, voluntary benefits. We have a joint meeting with the board with the board insurance committee, and that they took it to the board. And Trish, you want to tell us what happened?
The board did approve. AGM Benefits and Hub International is the new voluntary benefits administrator effective January 1st of 24.
Cool.
We are currently working through the process. It's a long one. We've been having regular meetings with both Hub and AGM Benefits to market everything, take a look at all the benefit options available through voluntary benefits, we don't really have any details. We're still in the planning stages of everything, but at least you're aware that we will be making that transition. They will come on board during open enrollment. We will be in preparation, so the employees will be notified. We're looking towards an open enrollment date of September 11th through the 10th of November, where benefits would be effective January 1st.
Anyone have any questions?
Just a comment, just a suggestion. At the meeting itself, it was said that, for the bids and so on, that we were just going through the motion because the district was satisfied with the person that we had. That could lead you into a big lawsuit by doing that, saying that. I would suggest not to say that again.
Are you referring to me, perhaps?
Well, you're the one that said it, so.
Oh, no, sir.
What?
Absolutely not.
Absolutely what?
I didn't make that statement.
Wait a minute. It was said that you were, we were, and it was said that we were actually satisfied with the firm that we had, and that we were just going through the motion because, well, I wish Katie were you here at the meeting?
Yeah.
Okay, did you not hear the same thing?
Justin Santani did.
I think it was stated, but it wasn't stated by our department, Ms. LaBeouf. It was stated someone else, but it was not stated by a staff member from the insurance department.
No, it wasn't my statement at all. No, sir.
Two questions, Trish, if we could.
Okay.
Since previously we had just the one company, now we have two companies. How does that go cost-wise? Are we paying both company, Hub, and is there an additional cost?
There's no cost for voluntary benefits.
I understand that, but is there an additional cost for the voluntary benefits themselves to employees? Because
There's a cost for premiums, yes, ma'am,
Is
to
there
employees.
now my question, is there an additional cost because we're using two companies?
No, ma'am.
Okay. Second question, we were talking about before the meeting. The only retirees who have voluntary benefits are those who had them when they were active members, correct?
Correct. I mean, the members have transitioned from active to retired. That's how you get your reported benefits after
Is
retirement.
there any additional cost to the board if we were to have open voluntary benefits for all retirees who might want them?
Open voluntary benefits. Meaning, explain your statement for me, please.
What if I wanted to buy a cancer policy, but I don't have one now? Can I come to an involuntary?
You have to be an active employee in order to enroll in benefits, to which you wouldn't be. No, ma'am.
Is that a board policy? Is there
No, it's not a board policy. No,
Is
ma'am.
there a reason that we could not open it to retirees? Because I get asked that question a lot, and I don't know the reason.
Brooke, you want to speak to that, perhaps?
About opening up certain lines to retirees,
Right.
like dental, vision.
It would obviously be more expensive for retirees, no doubt.
Yeah, I mean, it could potentially be more expensive, and to be honest, most people don't open it up later on just because the cost for claims for an older member can tend to be higher than an active employee, so it kind of will affect the risk of the group, and it could potentially affect the active population rates, to go
Okay.
up.
I understand, that makes sense. I just never had a reason, so, thank you. Any other questions for Trish on voluntary benefits? Next item on the agenda is review of board policy EGA. Trish, the pertinent item, and all of you should have a copy of it, because Trish very kindly sent it to us. We've had an issue several times this year about involving the 30-day limit. So Trish, that was why we included that. If you could explain what that is and your parameters for it.
If I'm understanding why you wanted it put on the agenda, EGA, board policy EGA is with regard to staff insurance coverages. I believe you're focusing specifically on the refund portion.
Right.
Correct? Okay. The best way I can describe it is LPSS is a self-funded group health insurance plan. You guys know the risk. You've been sitting here for months on end, years on end, being a part of the committee, you know that that's our liability. There was a board policy created and revised. 2015 was the last revision. That piece was added to it. It basically states that refunds to members is a maximum of 3 months when an error is found, whether it's found within the department or whether it's found by the member themselves. So let's just say we sent out that recent communication with regard to the 4% premium increases. Members may have reviewed the premium increase chart with what was either coming out of their payroll or perhaps their pension, and may have noticed that, hey, I'm under Medicare, I should be receiving that discounted premium. Why am I not receiving the discounted premium? In that example, if we don't have a copy of your Medicare card, we can't do additional verifications, ensure that you're running Medicare primary. We can't vet that you're no longer working, you're an actual retiree. There's several steps within that process. They have to fill out forms, we have to vet them. And if they don't return that information to us, then they're going to stay at the same premium to which they are. If they bring that to our attention in that example, then the normal rate is $165. The new rate, if they are Medicare eligible A and B, is $96. So the most that we could do would be a reimbursement of the difference between those two premiums for the member with a maximum of 3 months. Let's just say that change may have happened in 2022 when they became Medicare eligible. And now we're catching it now. We can only go, right, because it was brought to our attention, we can only go backwards a maximum of 3 months. That's to protect your self-insured health plan too. I mean, there's measures in place within board policies and various board policies that protect members and employees and the district as a whole. Yes, ma'am.
I know retirees don't know that, because I've had people call me, they were in that exact situation, and paying, let's say they want Medicare a whole year, and they were told they can only get 3 months. Is there any way you can, communicate that so everybody will know that if it is a mishap, whoever makes it, you're only eligible for 3 months?
It is listed on various forms and documents. We've started adding it to numerous pieces. We also include it when we communicate with the active members in particular. Let's just say we've got all these new hires coming on board right now. They're going to be enrolling in group health insurance. We provide them with a confirmation email that references board policy EGA. Please refer to it. It's a clickable link within that email. As you know, sometimes it doesn't get looked at or perhaps reviewed, but we've been communicating regularly to the retirees too. We can include that as a piece of a Blackboard message. It is listed on the website. It's listed in various different locations.
And maybe the next time you send a written communication for whatever reason, you just put that in there as a refresher, a reminder, because retirees don't know that.
The best way I can say
The
it
new
is
retirees, they don't know.
we give them a retiree packet. Ashley sits down with them and has a consultation. 9 times out of 10, they'll see Miss Pam in HR. Then they'll come and see insurance because they want to know how to port those coverages and continue them after retirement. So they're having discussions.
But then you lose some people, because this young lady just retired, and it was a year, and she did not know that. And sure, she got the packet, but somehow she did not know that information. And of course, she was upset, but she paid a whole year, and she was only getting 3 months back. So just communication.
We can definitely do that. We can add a piece for it, but we've been communicating regularly, especially since the addition of that Blackboard messaging that we've been sending out. Like I said, it's on various forms, different locations on the website. It's within our email communications. We are constantly redirecting to reference those board policies. Now, granted, it's a dual responsibility. You know, the member does have a responsibility too. They've got to make sure that, just like the active members, they have to check their payroll to make sure that the deductions that are coming out of their payroll are accurate. Same instance for the retirees. You've got to double check your pension. I actually spoke with Mr. Butch the other day. He popped in. He asked me a question if I could reconfirm some stuff this evening with regard to the Medicare cards. But he reminded me that the retirees under TRSL, please correct me if I'm wrong, they do receive a monthly mail out of what your deduction is from pension, correct, Butch? A monthly?
No.
You don't get it?
You have to
What are you talking
request
about?
it.
Yeah, I don't
What
get
are you
It-
referring
It's
to?
like a check stub that says,
Yeah.
this is how much you have, this is what we deposited.
See, I thought they sent it once a year.
Yeah.
We had that discussion.
Once a year.
Okay.
We'll probably get one for July, well, it is fiscal year, but the increase started, so you'll get one for that.
Yes.
Okay.
When they
When they make a
When
change.
there's a
Once a
change.
year and then a change.
When there's a change,
Yeah,
okay.
correct.
Because
That's correct.
I had a discussion with him and I said, you're getting it monthly? He said, I'm getting it monthly.
Hang on, I think I'm having
It
it.
did say July on it.
That's exactly.
You must be changing stuff.
And Trish, that may be.
Carol, you have the floor?
Mary Jane's job.
Oh, Mary Jane, I'm sorry.
That may be a reason why some people is not noticing this because of the lack of communication between retirement and customers. I don't get that.
The lack of retirement, you mean between TRSL?
With
Perhaps?
the statement saying whether it's coming out to retirement,
Okay.
that's not given to
You do have some options. I know everybody's not
I can
tech
go
savvy. You may
online.
not have access to a
Everybody
computer.
doesn't have online, don't say
That's
that.
right.
I totally
Chinese.
understand that. There's some members who don't have it,
Yes.
even with active members too.
Right.
But it is available. You can create a login through either Teachers Retirement or ELSERS to view that information, because in all honesty, it's important. And I would suggest if you do have access to it, to definitely create an account. That way you're double checking what's
Again.
coming through.
Elderly retirees, don't do that.
Right, but you do get at
That's
least
why
the
the
annual
written
statement.
communication,
Yes, ma'am.
that's how they get their
You're
information.
talking about mail, right?
By mail, period.
Yeah.
I mean, 60 cents, is not gonna kill us. That's what I'm trying to say.
Okay, I have a question, Trish, and it's probably not for you, it's probably for Matt.
Okay.
You ready, Matt? Yeah, and I wasn't aware of the policy, but that's my fault. I mean, it's obviously policy. It's dated as to when it was adopted, so it is policy. My question is, if it is reversed, let's say LPSS overpays somebody, and that has happened. I knew it happened to an assistant principal.
Yes, yes.
And that person was overpaid for 3 years and made to pay back every penny. They gave them some time to do it.
What's the difference?
But so is that policy, does it cover that? And I know it's not dealing with insurance, it's dealing with salaries actually. But Matt, they are made to pay back if they're overcompensated, is that correct?
Right,
Yes.
that's a constitutional, you can't give anything away that's not earned, so our attorneys would tell us we have to attempt to get it back.
I understand why, I mean, I'm not arguing, but it seems as though if we can go back 3 years, we could.
Yes.
pay
But it's the
back.
A year.
reverse, because it's the reverse on the employee's responsibility as it read is to check even in the overpayment. So if I had a job that, I took a new job and I was overpaid and I knew my salary, yet my paycheck was a lot more than what
Yeah,
I
I
was
would
supposed to
report it
say.
immediately.
Right,
Absolutely.
then I would need to report that because I would be making money for that. So I have to go back and recoup that money. So it's the same on the opposite side. It's my responsibility to check my benefits and my deductions or report. So if I got a divorce and 2 years, I've been paying premiums for 2 years and I didn't have a husband anymore and I never reported that, that was my responsibility of reporting. That's why the open enrollment piece is so important on that for there. So I think that's the difference on it.
No, it's not really, because when people retire, they come to you, and they do whatever you tell them to do. So then when they're still paying for something, and they think they're not paying it, and they're told, yes, you've been paid for it for a year, but I can only give you back 3 months. What's the difference? I'm just trying to understand.
And that's my point, it's like, if we do it,
Yeah, what's the difference?
and
Well,
I
their
understand
problem-
recouping the money because, you can't operate that way. But this.
I think if it's gonna be changed, it has to, the policy would have to be changed.
I agree,
Yes.
think
I agree totally.
I don't think it's the insurance department, I think it's the policy itself that needs to be changed, but if you communicate with the retirees rather than referencing a board policy, if you could just take that section that deals with reimbursement,
Yes.
and highlight the 30 days, because there are a lot of retirees who have no idea. We had 2 situations this year that you and I talked about, and I know that one of them knew, she knew 2 years ago, but this latest one was someone who called Carol, and Carol told her to call me. And she was, she honestly was not aware.
No.
And I did not, until I contacted you, did not have a policy to give to her. So, and as far, I don't know if she's back in the country, but she was leaving the country, which is,
She's back for the moment.
she is back. So
We do need that additional info. We do need the form filled out. We do need to vet the member. You don't want the member running Blue Cross primary and receiving a discount. So it's a process. That's why we're not aware when the member goes to the Medicare office to obtain their Medicare card. That's something that they do strictly with Medicare. We're not privy to it. So it's their responsibility. They've got to bring it to us so that we can then vet them and have them fill out our additional documentation. And then should they indeed be Medicare primary, then we can reduce that rate moving forward. But we're not aware of when the member decides to obtain
But that is
Medicare.
the information we have pushed out, that when
Yes.
you do that, you have to let us know. And so if our retirees would let us know, and we have communicated that piece, if you let us know, then that allows us to help, which would have prevented the year lapse and paying extra money. And so while we didn't communicate the refund of the 3 months, we communicated that the change needed to be reported so we could help you with that.
We've had Medicare communications at least 3 times, actually, correct me if I'm wrong, at least over the last year at the minimum.
So was this, when you said the last time this was amended, the 30 days was added in 2015?
If I'm remembering
3
correct,
months.
there was lots, almost the entire policy was changed back in 2015, not just that specific section.
Okay.
And when Forethought did the whole overhaul of all the policies?
In 2015, the Forethought did an overhaul of most policies. I think y'all were both still here.
We were retired.
Yeah, we're retired. I'm so sorry.
That's why I didn't
We're still
remember
here.
the policy.
But there was a huge overhaul in policies, and when we reached out of why, one of the main reasons of setting the time limit is because we are self-funded. We have to protect ourselves as a fund because of it. And so that was the reasoning why it was put in at the time is what we could find in research.
Well, somebody selected.
Because I wasn't here in this part in
Instead of 60 days or 90 days, somebody selected the 30 days and recommended that to the board.
3 months.
3 months.
I mean,
3 months, not 30
or
days.
6 months or 9 months or 12 months.
I think 90 days allows you to go through a couple pay cycles in order to, if you think 30 days, a pay cycle is really hard, you get paid, you would never be able to find it. A 90-day allows you to give you a couple of pay cycles to go through, look, I have something going on this month, but I might catch it next month. So 90 days gives you a really good window in order to catch that,
So
I think is
now that you
why.
have somebody in insurance dedicated to retirees, which was a very good move in my opinion.
She's been wonderful.
Is there not a way for you to look at the list of retirees and the list of Medicare cards you have? To find which ones we don't have?
Every single year, we've been getting additional reporting information from Blue Cross. It's kind of like with any business, you progress. That's the place we are with Blue Cross. Previously, we didn't receive that reporting. We did not have that at our access. But now we are receiving CMS reports to where we have the other, and we are doing auditing within the two to make sure that we have that, which is
So
how
this
some of
shouldn't
these
happen.
communications are happening with members. The member that you're speaking of, it was caught through an audit. They did not bring it to our attention. So,
But, I'll tell you, when you get to that retirement age, you're not thinking about, do I get a discount? You just don't. I mean,
And they rely on you.
and I think what she's asking,
Yeah.
is there a way to follow up, okay, this person's, and a lot of people retire at 55 or 56, 7, whatever. And, those years go by, man, you're traveling. I mean, it's just, those years fly by and you don't really think about, what the payments are, and then that has, if there's a change, you understand that. But there again, I don't think you think about, I'm gonna get a discount when I get to be with Medicare. With the years of when you leave this system and you get on Medicare, you may not pull it together.
Well,
It's a
if from now
choice.
on, what is happening is there is a list of retirees and there is a list of Medicare cards that are in the insurance office, they should be able to notify anybody who hasn't turned theirs in So there shouldn't be a problem.
There shouldn't be as many, and I think that was the key, I'm sorry, Trish, I think that was the key. Before, like Ms. LaBeouf said, we had no report that was being
Right.
provided to us that we could run who was having that forearm. And just because you're eligible, some people are choosing not for that option to stay in the Blue Cross Blue Shield. But we've talked about inflation and maybe somebody doesn't want that premium and opts for that. That was the push out, hey, if you go on it, you need to let us know so we can help you. But now that we have the report, the notifications to say if you go on it, let us know. Yes, we're hoping to catch, and that's how we've caught the last couple, is through the auditing purposes.
So they refused to get on Medicare?
You can, it's
You
a
can.
choice to elect Part B, it's not mandatory. A is earned, it's based on your work history.
Right.
Okay, so if you've earned it, then you have A, but B, you gotta pay for it, so it's a choice.
Well, of course, yeah.
So Trish, my question, when a person retires, on your form packet, do you ask them, will you be eligible for Medicare?
Oh, yeah, definitely.
So, okay,
Yes,
then
ma'am.
my question is, if they say yes, then what happens after that?
So when they sit down with Ashley, Ashley's reviewing multiple things. She's taking a look at everything from voluntary to health insurance. Those members who do have Medicare, she's covering those pieces too. If they have Medicare, we're getting a copy of the card, we're having them fill out some additional documentation. It's an ongoing, lengthy conversation when they sit down to have one with her. So it's not only given to them for print, you know, like me, I like to have something to refer back to. It's given to them in print, it's listed on our website too. There's a couple different media sources for the member. It's communicated through ongoing communications through the Blackboard, messaging as reminders. Not to mention, she sits down and has a verbal conversation. You know, some people may learn better by listening. I do better by having it in print, something I can refer back to, or writing something down. But, I mean, the biggest thing I would stress is members who have Medicare should be in contact with our office. We need to make sure that we have their information. We asked for a recent push with regard to the Medicare cards. A lot of the cards that we had on file were the older ones, the ones with the socials, versus the newer ones that are alphanumeric. Claims and billing can still process through correctly. That's not the issue. It's just that we like to make sure that we have a hard copy of that card that Blue Cross may or may not have in their records. Just to make sure that claims are accurate, we're charging the correct premium, everything's going as it should be.
Anything else about voluntary benefits?
Ms. Carol looked like she had a mess.
Because I'm still trying to process it. If Mary Jane retires today, she comes to you, she does all the paperwork, she lets you know she is Medicare eligible when she's 65. Maybe she is 60, I'm just saying. So you know that when she is 65, she's eligible. She's not gonna remember, oh, I thought, in a few more years, I need to call Trish to let them know I've received my Medicare card.
So, okay, so let me
Am I
pause
saying
you
that
there.
right? Yes. Okay.
So in order for Ms. Mary Jane to go get her Medicare card, she has to prove that she's been under group health insurance with our plan. She's gonna have to come to Ms. Ashley with a form, is what should happen.
But this is currently.
Or if they do it online, then they're bypassing Ms. Ashley, so they could. But 9 times out of 10, most retirees will bring that hard copy or will print it in our office because they like that face-to-face connection and they want to talk through the issue. And then Ms. Ashley vets it, and then that member has to take it. A lot of them like to go in person, they'll go to the Social Security office, and then that has our employer statement. So when Ashley's filling out the form, she's telling them, hey, when you get that card, bring it back to us, it's super important, and she's explaining the process moving forward. Correct me if I'm wrong, Ashley, chime in if you've got additional input, but I'd venture to say 85 to 90% of the retirees probably do it that way. We don't have a lot that tend to not want to go in person and they do it online. Because you could fill out your employer information, it could go through, the member could get the Part B, the Medicare card in the mail, and then we would be none the wiser. But at least for those members, a majority of them, they come to Ashley, they get a counseling, they get Ashley's employer statement that they're gonna have to take to CMS. And then she counsels them in the process as she's filling out the form. Does that help? So that adds an extra layer to it, because I understand what you're saying, but
The only problem that still exists, Trish, is Katie's. If people are overpaid by the school system, they have to pay every penny back. But if they are charged
They lost it.
a year, and they've paid too much for a year,
Yeah.
but all they can get back is 3 months' worth. It
It's
doesn't
unfair.
seem like those two things are fair. And I understand the law is clear that you can't donate public funds, so I get where the first one is coming
But then
from.
it shouldn't.
I just am
Money
confused
that doesn't
about
belong to them.
the allowance of the 3 months.
It's gotta, I'll just reiterate, it's gotta be a shared responsibility. We need to be cognizant of that and work it through and be aware of our deductions. I reiterate it all the time to active members, that's primarily who we speak with. Miss Ashley tends to deal specifically with the retirees, but I would caution, get online, try and check out that pension deduction coming from, just to make sure it's
Don't
accurate.
get online.
You got at least a 1-year statement at the minimum.
Well, you know,
Check that 1-year statement.
and one of the things is that with doing that, I think if reminders.
Right.
So like, you know, not just 1 or 2 a year, you know, but more reminders. Hey, if you have retired and you're on Medicare and you haven't let us know, because a lot of people today are doing everything online, okay? They're not coming here to do the Medicare, the Social Security thing. So in a sense, they're gonna bypass Ashley, okay? So I think it's just, if we could just simply, maybe 4 times a year or something.
I say, right, would we consider the fact of sending out, let's just say for the next year, every 45 days, since that's a halfway in the 90, which is the 3 months, a notice saying that if you're on Medicare,
It's a
please reach
reminder.
out because we have this
Thank you.
policy that
Yeah.
has
Right.
whatever.
Yeah.
And we can push it to all retirees, and
I
that
think-
way it's a halfway mark, so that would
Yes.
be what, 8, that many times a year.
Well, I think that would it would kick in the reminder, okay? And, oh yeah, I'm on Medicare. Oh yeah, well look, this is, I can get her to, look, it just mentioned, if you get the discount, don't forget your discount at the Medicare age. And I'm going, whoa, yeah, you're gonna think about it.
The good thing
It's the reminder that, because I'm telling you, you guys haven't got there yet, but once you've retired, man, there's grandkids you gotta worry
So we could 8
about.
times in 1 year, we could push it out 45,
That would
every
be
45 days to start, and then maybe the following year, won't have to, because we would have done a great complete cycle.
The only thing I would ask,
Here we go.
because just think of that for just one moment. 8 times 3,300 retirees. When we pushed out that Medicare mail out, it had my staff, I put all staff hands on deck, trying to answer phone calls from retirees. The only thing I'll ask in that process that we'll include in our communications is please do your due diligence too and double check your pension, and don't call us to verify that amount through pension.
Oh, yeah.
Because it would
I
be
agree.
overwhelming for the department and we won't be able to do daily operations. We just
And
won't
listen,
be.
You have to do it 3 times a year. Just do it, if it's
Yeah.
3 times a year.
Yeah,
I didn't know, listen,
a reminder.
I copied this policy because I didn't know it existed. I underlined things because I went, really? Really? People don't know this, y'all.
I know they don't know it.
Trish,
Yeah.
I do have a question.
We might be able to.
Trish, Katie?
There are a few,
I don't
just
know.
a few of us left that are not eligible for Medicare and will not be. And y'all do send out the notices, I get them, please bring in your Medicare card. I normally ignore it because I'm assuming you have on file that I'm not on Medicare. Is that correct, or should I be responding to that officially?
No, you shouldn't be responding.
Thank you.
We have
I
you.
figured y'all had enough phone calls without. Okay,
We
good.
did.
All right,
As Butch.
everybody ready to move on? Thank you, Katie, and Carol and your Jenny. And Butch. Trish, you're up next. Fund balance is?
I can give you the audited fund balance, Ms.
That's
Nancy.
fine.
I know that the accountant is still working through the current year totals, but the best I can give you is the 7/1 of 22, which is 6,177,334.
Repeat it again?
6,177,334. We did speak with the accountant. She's working through a few priorities, but that's next on her list to try and get you an updated one.
And that's it.
Any
That's
questions?
the
at the end
audited
of-
one. Yes,
At
ma'am.
the end of June, basically.
Yes, ma'am.
Okay.
You got it.
So we will have that audited number
You
by the
should.
October meeting?
Yes, ma'am, I don't see that being a problem.
Okay, next item, OPEB, Matt. It was,
By October?
The auditors usually issue in December unless they audit it ahead of time. Do we audit 85 ahead of time?
You don't think we'll have it by October?
Not, well,
Not officially?
unofficial.
Okay.
Doesn't, the audit
we'll
doesn't.
take unofficial.
Audit gets issued in December, so it'll be truly audit.
Okay, OPEB, this was brought up at a prior meeting by Brunel.
Yes,
He had
sir.
asked the amount in OPEB and how much in this year's budget is gonna be put in OPEB.
So total assets as of 6/30 unaudited, 18,842,926. And the total contributions made in fiscal year '23 from the funds, the funds that employ those employees through the insurance premium was $1,010,439.
1,010,439.
439.
Thank you very much.
Now,
Brunel?
those monies are normally invested, right?
So that
So
changes.
they should be
every
getting, not a
month.
lot of interest, but they should be making some.
Pretty good, yeah.
Okay.
Any questions for Matt? Next item on the agenda, Hub International, Lynn and Brooke are up.
Okay, everybody should have a packet.
Yep.
So, on the page one summary, not much has changed as far as participation goes whatsoever. We had less than 1%, almost equal, so 57.67 versus the 57.61. Obviously, that's gonna come up, and now with the people that are leaving and coming into the system this time of year, but not much of a change there whatsoever. You do see a pretty decent amount increase, 279 versus the 239 into the Humana plan, so that's positive. Medical claims right under 16 million at 15,879 compared to the 32 before. Remember, this is 6 months compared to a full year. We have the per employee per month numbers on the next page. Your prescription claims at 13,144 compared to the 24,290. Total claims 29,023,628 compared to the 57. So it's easy to see that we're running a little better. Remember, this is the first half of the year. This is a lower cost half of the year. Summer months are always more expensive, so just keep that in mind. Plan reimbursements, nice increase there. 11 million for the total year last year, and we're already at 6.5 million here. Same thing on the retiree drug subsidies at 1,463,000 compared to that previous number. Big increase there as well. Net claims paid down to 21 million, or just a little over 21 million, 21,069,000 there compared to the 44 of previous year. Fixed costs right on the money there at 2,040,000 compared to the 4,043,000 year before. And retiree premiums, when you look at 6 months versus a year, it looks like the premiums actually increased. The premium, if you remember from renewal, actually went down a little bit. You just have more members, more retirees into that bucket, so that's why that premium's up a little bit. From a total plan cost perspective, 23,470,000. When you compute that on a per employee per month basis, that equates to 678, which is a 4.1% decrease from the prior year. Funding, we're looking at basically 25 million versus the 50,566,000, so not much of a difference in funding. Actually, a slight dip in funding. What we're seeing in funding the last few years is we're hiring more single folks, so funding actually comes down on an average. So when folks aren't, but that is a good thing, okay? Putting more dependence on the plan increases claims, but at the same time, when you don't add the dependence to the plan, it brings the funding down. Okay? So it's still a positive for the plan because the claims outweigh the contribution there. Net employer cost at $16,035,000. Loss ratio, budget loss ratio at 94.1, leaving us on a calendar year basis a surplus as of June 30th of $1,468,000. Next page, breaking all of this down on a per employee per month basis, still the same thing, 4.1% decrease. One thing I'll add that we talked about at the last meeting, remembering, we kind of look at this on comparing a full year here to 6 months. I've already mentioned that the first 6 months is a little lower. When we compare the first 6 months of this year to the first 6 months of last year, it's almost 10% up. But that will decrease as the year goes on, and I'll explain to you why in further pages here. So medical claims at 482 compared to the 496, that's 2.8% decrease. Prescription claims are up about 8.7, net of reimbursements about 6.7. That's purely coming from the high-cost medications. We don't see any increased utilization in the plan from number of scripts or anything like that. The two areas that are showing up here is diabetes medications and the high-cost anti-inflammatories, which is basically the same two categories that we talk about each and every time we get together. We're going to see a decrease in the diabetes meds because remember we're putting in the prior authorization for the Ozempics and Mounjaros that people have been utilizing in some cases for weight loss. And at the same time, the patient's assistance and also the renegotiated rebates will perform real well on. So I foresee that prescription drug number actually coming down and maybe below last year's numbers with the rebates and all of that we negotiated. So total claims.
In those school systems where the insurance covers, Butch has asked this before, covers that, whatever you call it, the sensor that with the reader, Dexcom.
Omnipod, or what,
Do they see patients more compliant and therefore a reduced number in terms of medication? I mean, is there any kind of comparison?
Those types of monitors are really well liked and positive for the fact that they give you real-time data and can be quite beneficial. That's a totally separate kind of topic from the meds. Every plan out there has seen in the last 12 to 18 months a pretty big uptick in the diabetes medications for two reasons. People changed their eating habits and didn't take care of themselves as well during the pandemic. And then the other thing is the news is spread that these medications are effective for weight loss, and you had a lot of people doing that, and so everybody responded by moving those medications into a category that requires a pre-authorization. So if you're not a diabetic, you can't get the medication. So that's what's going to really have a positive effect on that. But as far as the answer to the question of those monitors, the folks that utilize them are real pleased with them. But not everybody needs a monitor from a medical necessity standpoint of that type.
But we do have something in place for the Ozempic use for weight loss.
We put the,
We don't pay for that.
went in
We only pay
about
for
the
it if you're
middle of June.
diabetic.
right.
Type 2 diabetes.
Type 2.
So we have to go back and reverse that out, or
No, so it went into effect. So actually when we
Okay.
made our changes in, when we did our 4% increase, we made our changes, and correct me if I'm wrong. So even if you were on a Ozempic, so for example, like I can say, if you were on a Ozempic and you needed to go get your another prescription of it, you already on it. At that point, they still made you go, even though you had been on it, go get pre-authorization from your doctor, even if you had been on it prior to.
so we're filtering that out.
Correct. So then you had to go back and your doctor had to say, yes, it was related to being diabetic. They
True.
were not issuing it correct based on weight loss anymore. So with that change in that, even if you had been on it, they made you go back and be recertified.
So it should be
Yes.
pretty clean in that respect.
Correct.
It's gonna take a little while. Okay.
Let me just tell you what happened to me. I was lucky I'd gone to my internist and whatnot, and I was able to get a sample of the Libra, the one on the arm. And my God, look, one of the things, like in the mornings I have my coffee, but I put my creamer in there. But I found out that high fructose corn syrup is a definite.
No.
I mean, it's like, I'm going from basically what we would say a normal reading in the morning, and that's when I have my coffee, I drink. And I mean, it's like, whoa, but I would not have known that, because when I get up, I take my blood sugar and whatnot, and I don't go do it right after I have coffee. But with that thing, man, I was able to do this all day long. I found out pasta's not too cool, stuff like that. And I've said this time and time again, but if we could maybe get Abbott Labs, just okay, so many, 50 cents per person, per employee per month or whatever. If we could get something direct with them for those who are on or have diabetes, I found out a whole lot, okay? I found out a whole lot. And of course it was a sample, and it was fantastic, and I wished everybody could do that. I mean, it tells you what, so basically I've brought my numbers down, not where I want them, but I've brought them down because I know now what not to do, so it's something to think about. And hopefully if I could do this enough, I would get off of some of the medications, it's an FYI.
They are, it does give you a wealth of information. At the same time, the industry is looking at medical necessity versus cost. And on those type of monitors, believe it or not, the cost is really not the monitor. The cost is in all of the maintenance of it, and going forward, it's the expensive part of it. So.
Well, the monitor is my phone. I slap it up there. I don't need the monitor that they have. That's an option, okay? But a smartphone will take it, and it shows it, and it gives you a log. And I'm going, whoa, this was so cool, Now, I haven't looked into just paying for it on my own, okay? But I understand they have something that says, well, if you pay more than $75 a month to talk to them and whatnot. So I'm just wondering if they would maybe not negotiate something with an entity like us,
Blue Cross is constantly, in the last 2 years, and all of the carriers have, trying to work out deals with all of these different monitor companies and offer that exact same use.
Well, if we could, it would be great.
Well, for all those people that take the Ozempic, the Trulicity, and whatever for weight loss, I hope they get as sick as I am. And I'm not doing it for weight loss. I am a diabetic, and I was just recently, 4 months ago, switched from a 2.5 glipizide twice a day that cost me $7 a month to the once a week Trulicity shot that now costs me $75 a month, and I'm sick constantly. I hope those weight loss people get as sick as I do.
They are. It
just came out on national news
out.
that there are
They're
adverse
not gonna be
effects
using that
for
much
people
longer.
taking it.
And then twice I've had to drive, I live in Tucson. I've had to drive to Youngsville because that was the only CVS that had it at the time.
Yeah.
They've been short twice.
Well, it just came out today, there are adverse effects on
True
people taking it
diabetics
for
not
weight
being able
loss.
to get their meds because
That may slow it
everybody's
down.
using the Ozempic in my jar, Guardians as well.
Mine was the Trulicity.
Problematic. Going back to the prescription drugs, you'll see the bullet, the top 10 medications. 3.3% of your prescriptions, almost a third of the medications. So it's obviously the high-cost meds that drive this. But plan reimbursements are going to be picking up a lot of this with the rebates that are coming in and the discounts, that type of thing. Also, like we said, we're going to see a big decrease in that utilization on those those medications. And then the patient assistance program that we put in is gonna have a positive effect on these high-cost anti-inflammatories. So all in all, from the prescription drug standpoint, I see that moving in a positive direction. Plan reimbursements, this is kind of in the same area, increased 18%, mostly due to the increased pharmacy rebates. We've had some high-cost claims, so we've got some specific reinsurance reimbursements and then also the COVID reimbursement. But even without the COVID reimbursement, your reimbursements increased some 11.4%. Retiree drug subsidies, 57.1%. The retiree premium from Humana decreased 3.2%. Total paid claims less, net of plan reimbursements down 4.2%. Funding, as I said earlier, down just at 1.4%. That's because we've had more singles, and then of course that cost decrease of 4.1%, and then net of employee contributions down at 5.3%. Page 3 just breaks all of this down on a monthly basis. Next page on page 4 shows the performance on a fiscal year basis. So when you look at June of 23 and you look in the bottom right-hand corner, we're talking about, or the far right column, the total plan costs for the fiscal year ending June 30th. And of course, all of this is going to change because you're going to have more monies coming back to it at about 53,637,000. Then total funding into the plan, 50,241,000, leaving us with a 3 million, almost 3,400,000, 3,396,000 deficit, which is going to take that number down. You've got another pharmacy rebate that's going to be coming in. You've got about 2,400,000 that's going to be coming in, and you take this down to about close to about $1.5 million is what we see here. So that'll bring that down pretty well. Going on to page 7 here, we kind of discussed enrollment. It's hardly changed at all, less than 1%. I always talk to you about membership. We don't, the membership change is actually less, so membership is not a problem. Enrollment by plan on page 8, that's all moving in the right direction. Enhanced plan is down about 3.6%. Basic plan down a little less than 2%. And Blue Saver up almost 4.5%.
We had asked what revenue was lost in Blue Saver.
Yeah.
How much revenue was lost in by the increase in Blue Saver?
By folks moving from that, well, that kind of addresses that. I'll take you to,
If you're gonna get to it, that's fine.
I'll take you to page 13. It doesn't answer it specifically, but those 3 bottom bullets there, the enhanced plan has 14.5% of the participation and 23.6% of the claims, whereas the Blue Saver has 24% of the participation, but only 13% of the claims. So the loss of funding from going from a basic to a Blue Saver, or even enhanced to Blue Saver, is nowhere near the difference in the claims, because you can see what the average claims are for one plan versus another. So Blue Saver enhanced plan claims per month are 58.2% higher than the basic plan, 194.9% higher than the Blue Saver.
Well, if you were gonna have health problems, you wouldn't be in the Blue Saver plan to begin with.
Yeah, it's common sense.
What's that?
If you were someone who employed a retiree who had health problems, you would not be in the Blue Saver plan. I mean, it would make no sense to be in the Blue Saver.
Unless you're looking at total straight max out of pocket.
That's why I was curious at the revenue loss rather than claims.
Taking you back to page 10. 2.8% decrease on the medical compared to 22. Once again, if we just look at the first 6 months of this year versus 22, the medical is actually up about 12.5%. But it will look towards some decreases with some of the measures that we've done. Prescription claims, once again, up that 8.7, 6.7 when we take into account the rebates here. But it will improve because we've negotiated those additional rebates, GAP, egg whip, all of that. And then the patient assistance and PAs on the diabetes medications. Total claims up 2.1% on page 12 here. Total claims net of plan reimbursements down 4.2. So all of the saving strategies that we implemented over the last couple of years working real well. So claims, healthcare increases, and claims are going to continually increase, but we've been pretty flat on that. I think once we get through this rash of cancer claims that we've had, things are going to stabilize a bit for us. But it's all of the saving strategies that have kept our costs down. We kind of reviewed page 13 already, but that move towards the blue saver participation-wise certainly helping us out. So when we look at total plan cost on page 14, this is probably a page we're pretty proud to show here, because from a total plan cost standpoint, we've kept it pretty darn flat. And when you look at the previous 6 years and you average it out, it's actually almost stable. It comes out to 0.12% of a change. Looking at claims by type of service, because the medical's down and prescription's up, prescription drugs are 45.3% of the total claim cost. That number's going to drop pretty well, okay, with these measures here. Inpatient utilization's up 15.2, outpatient down almost 12, and professional down 5.6. So what are our top categories here? From an inpatient basis, circulatory, we had some high-cost pregnancies, musculoskeletal, cancer. The circulatory is actually almost equal or down $1. You'll notice that the neoplasm cancer number is down. It was second at $15 per employee per month. It's dropped to 13. On the musculoskeletal, not much of a change there. It's just $4 per employee per month. I've got some figures on the Regenix for you that you basically kind of asked for in past meetings here. If you look at this particular, and I added these figures up, basically we were at $37 per employee per month in 2018, 38 in 19, 29 in 20, and it peaked in 21. We put in Regenix and we dropped to 28, and then this year we've kind of spiked back to 34, but we've saved about $1.5 million with the Regenix program, because the way you calculate those savings is an average cost of an orthopedic surgery, average cost of the procedures from Regenix are about $8,000, and you look at the number of procedures and calculate the cost. Matt asked at the last meeting, and this is what we'll have for you at the next, to kind of look at these members and figure out have any of them or what percentage of them have actually had to go back and have an orthopedic surgery after using the Regenix procedure. So we're going to put those figures together for you as well. On an outpatient basis, both circulatory and cancer are down. Factors influencing health stayed the same, and that's the area that encompasses chemotherapy. So and when we look at this data, it points towards a peak and starting to come down with regard to the cancer claims that we've been talking about at the last several meetings. Page 18, Lord still has the market share. When we total all of these up, you're talking about $200 per employee per month for facilities in 2022 versus $197. So we've come down a little bit, but Lord's still having the majority of that market share. I imagine that's what a lot of those cancer claims are, and circulatory as well. When we talked about prescription drugs earlier, I told you the changes in cost were purely from the high-cost meds. You can see here, we're still at 87%. For a school system, that's a very strong percentage. From 87% generic utilization means that you have some awfully compliant members. They're taking generic almost all of the time, very little brand name, 13%. Brand name medication, and the good news on page 20, brand is actually from peaking in 21 at 15% of your total, dropping down to 13. You don't see that much, so actually brand's becoming a little less of the total there. No change whatsoever in the number of scripts, 2.7 per employee per month, 1.5 per member. Page 22 shows us the top 10 medications by number of scripts. Nothing really alarming here. It's all of the things that you think that they would be. Once again, I've told you, when I look at this in other systems and I see tons of ADHD or depression medication, I think I'm telling y'all, you're a lot more sane than the other folks. It's hard to believe that. Top 10 medications by dollar amount. Once again, these are the medications that are driving almost 30% of the cost, and it's less than 4% of your scripts at 3.3. The diabetes medications are up some 38.7%. Anti-inflammatories up some 33%. The two programs that with the patient's assistance and the prior authorizations are going to work well on those. I think it's going to have a tremendous effect on bringing that diabetes number down, because you're going to have to be a diabetic to get those meds. At the same time, you don't see the Revlimid in the top 10 this year, which points towards positive on cancer treatment, because that's it's a chemotherapy med. PPO savings, once again, real strong at 69.6. This is one of the reasons that we remain with Blue Cross. They have a very strong network to give your employees choice. It's hard to find a provider that doesn't belong to the Blue Cross network. At the same time, having almost 70% discount off the bill charges is real strong for you. Network utilization remaining at 97%. And remember, when we came off of the 98.3 to the 97.3, it's not that you have folks going out of the network to non-network physicians. Most of that, 97% of the majority of that is Regenix and Thomas Bond. So it's positive news there. Page 26, 8.8%, 8.8 pennies on the dollar is what it costs you to run your plan. Folks, if we were going to a Blue Cross and you'd be fully insured, and weren't paying our own claims and they were taking all the risks, they would charge us almost double that. Okay? So from an administration standpoint, a reinsurance standpoint, and all of the things that embedded into your plan to process claims and provide disease management, case management, all of these things. Negotiating that every year and shopping the marketplace and as deep as we do on the reinsurance has certainly kept our fixed costs down. If you remember, in the beginning of the report, fixed costs hasn't gone up whatsoever. So if we can dedicate basically over 90 cents on a dollar to paying claims, we're doing the right thing. This is a health claim. Okay, that's what we're here for, is to pay claims and not have another 8-10% dedicated towards administering the claim. So that's worked really well for us. Contribution analysis, total claim cost, net of employee contributions down at 5.3%. And it's a big number, you've got to look pretty far back to see that. So all in all, first half of this year shows good numbers. We're higher than where we were in the first half of 22, but these saving strategies that we've implemented will have a very positive effect. I'll be loving to report to you the increased rebates that we're going to see into the plan and the positive numbers on prescription drugs and the next few reports, and I think we'll end this year in good shape unless we see some kind of spike in claims.
Questions for Mr. Fontaine?
I do have a question, Lynn. It seems as though the last few reports, Lourdes has seemed to be the hospital of choice. It used to be Lafayette General. And if I recall, Lafayette General, which is now Ochsner's, gave us the biggest discount. Is that still correct? Okay. Is there any way we can renegotiate with Lourdes, since I think we're one of the larger employees in the parish, about maybe a better discount?
So that's one of the things that in this 8.8% administrative cost that we just talked about, Blue Cross is a provider relations department. They're constantly looking at all of that. I will tell you though, post-pandemic, about every hospital in the state of Louisiana is going Blue Cross and it's money. Because think about it, with their market share in this state, them along with United Healthcare, you know, those contracts being renegotiated constantly. So the fact that you have the carrier with the most market share going, they swing a much bigger stick than when they walk into that hospital's finance department than we would on our own.
Oh, I agree.
So we're breathing down their neck to do that constantly. I'm puzzled as to why it changed. Was there something that went on in the community that switched? Because you had several years of the general getting the majority of it. From a diagnostic standpoint, we know what our top diagnostic things are. Maybe the lack of musculoskeletal that was going to Lafayette General could have put.
No, because now Ochsner's, which is Lafayette General, has opened their own orthopedic hospital.
Yeah.
So, and they're actually getting more than Lourdes is right now. So I don't think it's that. I think the fact that maybe Ochsner's is so large, people prefer
And if it
a
costs more
smaller.
than the dollars going, if you look at it strictly as a dollar comparison, if it costs more, it's gonna be higher than the thing, but I think from your question on Blue Cross, so Blue Cross goes out to negotiate these
Yeah.
prices. And Our Lady of Lourdes has a monopoly in a couple of parts of the state. So they don't have to negotiate as hard
Oh, really?
as Lafayette General. So historically, that's why we get better. Because when they go to Alexandria, Monroe, they're the only hospital in town. And what is Blue Cross going to say to those people they have to cover in Alexandria and Monroe that only have Our Lady of Lourdes or whatever it's called over
Okay,
there?
that makes sense.
So part of that historically is they've been able to get away with it because they have a monopoly in certain communities.
Okay.
We're lucky here to have two very highly,
I agree.
very good hospitals, and I think MD Anderson may be coming to Ochsner's, which I
Yes.
think would be really
Yeah,
good
a
because
real plus.
MD Anderson's one of our high one of, usually the top 3 or 4.
Exactly.
Not to mention convenience of our own employees not to have to drive to Houston
Yeah.
and stay in Houston and spend money at a hotel.
Yeah.
And when you have cancer, the last thing you want to be is on the Interstate 10 for 4 hours. So
I
I
agree.
think we might see that reversing.
That makes sense.
They do, but that's part of it.
Okay.
And those little nuns are tough.
What's that?
Those little nuns are tough. They pray a lot, and they get what they want.
They have connections.
They have connections,
My
straight
other
up.
question is there any update on the buyout of Blue Cross?
Yes, you had told us you would know by June if there were going to be a problem.
I hear no problems whatsoever. I've seen that they've had some, posted some meetings and things like that, public meetings, if people wanna come and do anything.
But they're still moving forward with it?
Nothing negative whatsoever.
So you expect the claims to be paid as easily and everything to be the same when they switch over?
There hasn't been a change in anyone's, management. I haven't seen any movement from, any account reps or anything like that.
But it goes into effect
Still been
next
status
January,
quo.
right?
January 1.
Yeah. So it doesn't go into effect until January
January.
of '24. Okay.
If anything, I think that it could be positive to bring in some synergies on, self-funded plans.
Any other questions
You know,
from
they
Mr.
should be able to
Thompson?
bring in more technology and things like that they share with all of these other Blue Cross entities and not have to, that should bring some costs down, maybe we get that 8.8% down a little more.
Yeah, they'll be able to integrate with a lot more savings vendors than they can now. So if anything, it's just gonna bring potential for savings a lot higher because we'll be able to integrate different savings tools that we can't integrate now.
What she means by that is that Blue Cross's systems that they use here in Louisiana, now being able to use more robust systems that they share with these other Blue Cross entities, you can bolt on Blue Cross. You can't bolt on a lot of saving strategies that you can with big national third-party administrators. So that should get more flexible, bringing us more opportunity to save more.
Okay, so basically, we know that Blue Cross Louisiana, Blue Cross Texas are 2 separate entities. When we're going with this one, we're gonna be combining, what, it was like 13 or 14, I think, Blue Crosses they bought. So that's gonna all be under one umbrella now? Okay, and that's what we're saying? Okay.
Anything else from Mr. Fontaine? As always, we appreciate it. Lynn?
Thank you.
My report, I'll send out a notice that our October meeting has switched to that Wednesday. And the only other thing, Trish, we had several, I think 5 excused absences. Not everyone absent is excused, but 5 of them were, because you're keeping a list of who gets close to the. Oh, you are? Okay. So I want you to know that some of the people who are absent are excused, and Vicki has that. Trish, your report?
We had our Osher's Lafayette General Medical Center Wellness event for the retirees at VCC. On 6/13 and on 6/22, we had a lot of participants. We had 44 on June 13th and 54 on June 22nd. So I think it was a great event. Yes, ma'am.
I wrote that question while Mr. Lynn was talking. He said that there was a decrease in premiums for Humana. If you guys are writing more Humana, why is there a decrease in premiums?
They're increasing as we go along is what's happening. Remind me, Lynn?
The
So
decrease,
first page showed that we paid more in the first 6 months to Humana, okay, than we did last year.
Right.
The
Okay.
premium went down, so I'm explaining that by saying the reason the premium's up, even when the rate went down, is because we've got that many more retirees
Okay.
onto the Humana plan.
Because we definitely have a lot more. We've added quite a bit.
We
Over,
went from 239 last year to the average is 270.
So it's going well. We'll have another Humana event. It will likely be a remote type webinar on the next one, just due to when it falls within the year. We discussed, Butch asked me to just reiterate with regard to the Medicare card clarification. I think we discussed it fully, but let me just try and hit some hot topics. So A, if you're under Medicare and we do not have your card, meaning when I sent out the Medicare notice, when we sent out that one pager, we sent the premiums with it too. If you are running at that reduced premium, we have your Medicare card. That would be the easiest way if you're trying to do a double check. Would we prefer to have those new cards that don't have, the older cards had just the social? Would we prefer to have the alphanumerics? We would, but we don't need that. We would be lambasted with that information if it all came our way and 3,300 retirees sent us their new cards. That would be a lot of information. So the main thing I'm asking retirees to do is to look at the premium sheet. And if you're running at that reduced rate and you're under Medicare, then you're good to go. If you're running at the full rate and you have Medicare A and B, there's cause for concern, and I need you to contact the department so we can do some research on your account and we can get you hooked up and we can work through the process with you. So A, either log into your TRSL or Elser's account and check your account to see what your premium's running at. Or perhaps you get a monthly statement like Mr. Butch does. If that's the case, confirm your premium information with regard to the reduced rates under Medicare under our plan. That would be my best direction. If you absolutely are confused and you've got questions, just reach out. We'll help walk you through the process. We'll make sure that we have the correct information on file for you. Okay? And then I've taken notes with regard to our statements earlier. We'll backtrack. We'll make sure that we're communicating and reminding members that they need to contact us. And we'll reemphasize that board policy too.
Please.
Just a quick recap. I sent out the flyer to Ms. Nancy in May with regard to that public health emergency. We also sent it to the retirees through the Blackboard messaging. Just a reconfirmation of that. I believe that's going to help us with regard to self-funding. It will help us with regard to self-funding. New hires no longer, we don't put them on per the date of their hire any longer. They go back to the first of the month following 30 days of employment. So we're not immediately placing them on the plan should they enroll. So then that liability and that cost won't be ours. They're also shifting, they're making the COVID vaccines onto a wellness benefit, kind of like your flu shots. And what we get through our wellness benefits through the vaccines. And the antiviral medications, they're still going to allow those. It's going to work through your typical prescription coverage where you're going to have a cost share like any other prescription that you fill under the plan. So prior to that, we were
dealing with administration fees and all that.
we had a lot more costs coming at us, whereas now it's going to be a cost share. And it's going to be run through various different entities to include the new hire benefits where it won't immediately become our cost. So in my opinion, it's going to be a great thing. I just wanted to reiterate that. And I did want to make note, we did receive a COVID reimbursement. We received the second under ESSER 2 for COVID reimbursement. It was applied to fiscal year 22-23 in the amount of $1,039,954.39. I can give those numbers again if someone wants to record them. But it was for claims under COVID from September 1st of 21 through August 31st of 22. So that's good. So we've essentially received over $2 million through COVID reimbursements,
So is that the last
which we
one,
definitely
Richard?
needed.
You think that'll be the last one? Or-
We are in converse.
There's more.
Okay.
Yeah.
Yeah, I know you don't know right now, but, okay.
The good thing is we're still tracking the stuff separately,
Okay,
and we're going to maximize the maximum.
Sounds good, thanks.
And that's all that I have.
Anything else? Before there's a motion to adjourn, I've been negligent. Those of you who were here earlier, Mr. Touchette, the new interim superintendent, introduced himself. I should have introduced him earlier. Welcome to the Employee Retiree Insurance Committee. You learn a lot, you really do. Do I have a motion to adjourn?
I so move.
Is there a second?
Second.
All those in favor?
Aye.
Opposed? Thank you very much, everybody. And before 7 again.
But
Good, how?
I still ran a little